Hi, welcome everybody. Thanks for joining Walker this morning as we're gonna go over overdose treatment and response. So we're joined here by Thea Wells. She works for the public health in Seattle and King County. Her current focus of her work right now is expanding access to harm reduction services in the community and helping to facilitate a council of people who use drugs. Thea has been working in harm reduction programs, serving people living in homelessness in Seattle for over a decade, and brings lived experience with injection drug use, homelessness, and finding safety in harm reduction people and spaces. So Thea uses both personal and professional experience and has worked to lower barriers to care for people who are experiencing homelessness. And those with trauma history. So we're really grateful that we have Thea here today to talk about this topic. Just a little housekeeping things, if everyone can keep themselves on mute. I'll be monitoring the chat, so feel free to put your questions in the chat as well as raise your hand, and we'll take questions along the way. So, and we also will have the slides available that I can send out to you after as well. So Thea, if you want to go ahead.
It helps if I'm unmuted. Try to keep that going. Thank you so much for having me. I love harm reduction work. It's my passion, my religion, and
Thea, you're muted again. I apologize.
I just said some really smart, juicy things. Anyway, I'm going to share my slides. Oh, there's people who say they can't hear.
Yeah, I think it's because you got muted on accident.
I got muted.
But
okay.
We can
hear you now, people?
Yes, I can hear you now. Yeah.
Okay. Back to life. All right, can you see my slides? I can't see you, so someone will have to.
Not yet. Did you hit the screen share button down below?
Yeah. Okay, I'm going to end it. I'm going to share it again.
We got it.
Good to go?
Yes.
Excellent. All right. I'm Thea Oliphant-Wells, or Wells in my personal life usually, so you can call me either. I have worked for public health for the last several years, both in syringe service programs, low barrier Suboxone, and now I'm on the overdose prevention and response team. And I love to train people and hopefully talk about my own experience of overdose, both as an overdose victim and responding to overdose. Working in a syringe service program with an active bathroom has given me a lot of opportunities to treat overdose and to view how overdose is treated and responded to, and hopefully improve the way that we do that. Today, I'll talk about drug supply and overdose trends. One caveat is my slides will be a bit King County focused. I apologize for that. I usually try to be really specific about the population. There is some state stuff in there as well. I would have beefed up my slides for you if I didn't break my toe yesterday. But we'll talk about some of those overdose trends. The King County supply certainly is similar to the drug supply around the state. Trauma-informed overdose response, which is one of my favorite things to talk about, because not all overdose response is created equal, and trauma is definitely something we should consider. We'll talk about overdose education and counseling when you're sharing that information with others. What are the most important points to make sure that you share, and then some resources. So, drug supply. I'm sure that no one is surprised to hear that overdose rates have been going up exponentially. You can see on the right side that dark blue line is fentanyl. The dark red line is methamphetamine. Those are our two top drugs of overdose currently. You can see that the heroin line, which is sort of a teal color, is going down. And that has a lot to do with the lack of availability of heroin in the community and the overabundance of fentanyl availability, as well as the fentanyl is just getting cheaper and cheaper as we go. Fentanyl is most commonly found in these blue pills that folks, I think these days, are usually just calling them blues. They also can be called perk 30s, M30s, perks, street perks. But you can see an example of one of these fake pills here. It's modeled to look exactly like a prescription oxycodone on purpose, so that some folks will think that they're really buying legitimate prescriptions. Because it is an illicit fentanyl product that's made in an underground lab, there isn't any of the same sorts of quality assurance that we would have with a legitimate pharmaceutical. And so the potency from one pill to the next can vary very widely. And some of the fentanyl analogs that they use are so potent that really just a teeny tiny bit can be enough to be fatal. We're also seeing some fentanyl in white powder form, both sold as powdered fentanyl, and also folks recently, more so, have been accidentally buying fentanyl thinking they're buying cocaine. So far, there hasn't been a lot of mixing of fentanyl and stimulants in our drug supply, though recently there was several crack-associated fentanyl-related overdoses that seem to imply that that may have been changing, but we're keeping a close eye on it for now. And we here at King County Public Health are in a really unique position. We have our medical examiner's office and our Washington State Patrol Crime Lab all working together on our overdose situation. And so we're meeting regularly to go over what drugs have been a part of overdose situations and having those samples analyzed to really find out more about our drug supply. Here's just another visualization of our fentanyl fatal overdose numbers. We're definitely on target in 2022 to surpass our 2021 numbers, unfortunately. When we talk about fentanyl, we definitely want folks to know that it can come in any drug, but right now what we mostly see is fentanyl in blue pills and white powders. Naloxone works on fentanyl overdose, but it can take more naloxone, so that's something to consider. It's absolutely safe to respond to a fentanyl overdose, despite some weird reporting of misinformation about fentanyl risk, mostly coming from first responders who I think mean well and are sharing information that isn't based in scientific evidence. We have campaign posters about overdose that are available. I don't know if that would be any interest to you, but the link will be in the slides. For opioid overdose, it's definitely important to identify folks who are at risk. And of course, folks who are living in recovery housing are oftentimes an at-risk population. So if folks are using opioids, they may be at risk, especially if they're using opioids that are manufactured illicitly and don't have that same quality control. If folks are in treatment for opioid use disorder, even if they're taking methadone or Suboxone, They may be at risk if they have a history of OUD, especially those of us who are in recovery. Folks who have been prescribed a high dose for a long period of time. A huge factor is whether the person has survived a previous overdose. And so if you have friends, residents, family that have survived an overdose, letting them know that they're at risk for another one. If folks have a reduced opioid tolerance, like they've been in jail or they've been in abstinence-based recovery, we definitely want to make sure that they know that they're at high risk for overdose if they were to be exposed to opioids again. And so folks who are coming out of withdrawal management, inpatient stays, incarceration, or just, living their life opioid free may be at risk. And then mixing substances, of course, is a big risk factor. Of course, those potentiating substances like alcohol or benzodiazepines mixed with opioids are the biggest issue because 1 + 1 does not equal 2, it equals 4. It intensifies when you mix those things together. And so definitely making sure folks know that that's a risk, as well as stimulants mixed with opioids. Back in my day, I used to mix those two a lot, and we thought that they sort of counterbalanced each other. When you go up and you go down, like it's going to keep you from overdosing, right? Not the case, because opioid overdose is depressing your respiratory system, your breathing slows way down, and with stimulants, that meth is going to require more oxygen. And so it's stressing your respiratory system in a different way. And so using meth and opioids in combination can increase your overdose risk. Signs of opioid overdose that you definitely want to look for. Someone who's unconscious and unresponsive is usually a good cue that they need medical intervention, whether or not it's an overdose. Shallow. Did somebody have a question? I heard a little blip and I don't want to just continue talking at you if you do. Okay, I'll keep going, but please interrupt. I can't see anybody's faces, so if you raise a hand, I won't know. Slow, shallow, or absent breathing. Abnormal breathing sounds. Now, this is a big one, especially in recovery housing. I lived in Oxford House and did a lot of service with Oxford House for many years, and showed up at a house following an overdose of a Oxford House member. And the girls in the house had heard her struggling to breathe, and someone actually commented like, God, it sounds like she's overdosing. Wow. And that's what was really happening. And so if you hear abnormal breathing sounds, please check on someone. It'll sound like snoring that's really laborsome, or gasping or choking. So definitely listen for those abnormal breathing sounds. Cyanosis, which the lack of oxygen will cause fingernails or lips to turn blue in someone with my type of skin tone. If someone has darker skin tone, they may look more gray or ashen. And so it's important to talk about that. We used to say, oh, blue lips and fingernails, and, in that white centric way of training folks. And we've learned since then. So definitely, if you're training others on overdose, mention that cyanosis presents differently depending on your melanin. If folks have pale or clammy skin, vomiting, a limp body, a faint pulse, and you may or may not know if they've used drugs. And so really looking for all those signs together will help you diagnose. But if you have someone who's unconscious and unresponsive, hopefully the first thing that you did was call 911 and let them know that you have someone who isn't breathing. I personally don't say that it's an overdose when I call. I like to avoid the police rolling up. If you say it's an overdose, they show up first and can delay an ambulance arrival. And so I just say it's someone is unconscious and we need an ambulance, and I answer their questions. But that's my personal preference, is not to deal with cops. Is it an overdose or just a heavy nod? A lot of times people are like, well, I can't really tell. And especially if you're walking down the street, I mean, especially in downtown Seattle, you'll see a lot of folks who are resting, but probably not overdosing. And I usually stop and look for their chest rising and falling, and look at their skin color to see if I can see any changes. I will usually verbally say, hey, are you okay? I don't touch people first. That's my personal preference. People don't like to be touched a lot of the time. If they're not responding to a verbal, then I will try to lightly tap a shoulder. If that doesn't work, then moving on, which we'll talk more about stimulation. But usually if it's just a heavy nod, some of those things will arouse the person. They may, be slumped over, but when you call their name, they sit up and they're alert, and that would not be considered an overdose. So first, shake and shout. A verbal Narcan can be a really helpful tool. Hey, Joe, I think you might have overdosed. Are you okay? I'm going to give you some Narcan. If someone is just on a nod, usually I'm going to give you Narcan. We'll get them to be a little bit more alert, because nobody wants to get Narcan who doesn't need it. You can do a Trapezius Squeeze, which I prefer. I've done some overdoses on reversals with women with large breasts, and a sternal rub can be really difficult and awkward. So I do like a Trapezius Squeeze myself, though if someone doesn't have breasts, a sternal rub is pretty easy to do. And definitely calling for help when you realize what's going down. And now administering naloxone. I'm assuming that you guys would be using a nasal Narcan, though if you're using injectable, it's quite easy. And the video that's at the end tells you how to do an injectable naloxone. And so either way, you should be covered. You want to unwrap that package. It's really a simple thing to do. I had a nurse who got this new nasal Narcan, and she was it was so easy that she was not sure how to use it compared to the nasal that we had before that had several steps. This one, you just peel back that container and you've got it ready to go. It's all locked, loaded. You just put it into their nostril and squeeze the plunger, and it's going to put that Narcan into the person's nose, and it's going to be absorbed into their nasal cavity. And so they don't need to be breathing in order for the naloxone to get into their system. Wait a few minutes, at least 2 minutes. I recommend in between doses to see if the person's going to be revived. Those minutes can feel like hours. And so having someone monitoring time can be really helpful, because it's hard to know how long it's been, because in the crisis mode, time kind of gets weird, right? And definitely want to give rescue breathing. I know some of the CPR training that's happened, or basic life-saving training that's happened recently, has said we don't do rescue breathing. That's for a cardiac event. If you believe that an overdose has occurred, we highly recommend rescue breathing. And of course, that is up to you whether or not you feel comfortable doing that. I know in the space and time of COVID, that has, left people with some decisions to make around that. And we support you in making the best decision that you can, though just know that rescue breathing can be the lifesaver. And if you don't have naloxone, please give rescue breaths until EMS arrives. Stay with the person. Once that naloxone wears off in 30 to 90 minutes, those opioids may get back on the receptors. So you have opioid receptors and you have a beautiful opioid that fits in there perfectly. When the naloxone comes in, it like kicks that opioid off and it blocks the receptor and will not let any opioids get in there. And then it can wear off and let that opioid back in if there's enough opioids left by that point. And some opioids can last longer than the naloxone. And so we do ask that people stay with someone for a couple of hours following an overdose. I usually, like when I've been in clinic or in the syringe service program, asked someone to stay and hang out if they're not willing to go with the ambulance, which happens a lot. And you do your best with what you've got, but we definitely do prefer to send people for observation at the hospital. Now for trauma-informed response. Y'all, if you've overdosed, you know, it's really a scary situation to be in one time and place and then come to in another time and place. That was my experience. And so I really hope to impart some of these trauma-informed tips that I've learned along the way. Giving folks space is really a huge one. Oftentimes when someone is having a medical emergency, everyone gathers around and wants to be helpful and see what's happening, and you care about the person, but all of that attention can really be more frightening for the person as they come back. Let people know what's happened in a calm as you can way. I've had reverse someone outside on the sidewalk, and I just, was in their ear saying, "Hey, so-and-so, you've just survived an overdose. I gave you some Narcan. There's gonna be some folks in uniform coming. They're firefighters. They're gonna try and help you, okay? You're okay, I'm gonna stay with you." I can't emphasize how far it can go to just have like one friendly, kind, gentle voice in the space. And oftentimes first responders come in hot and heavy with a job to do. And so they're not taking the time to be that calm and reassuring voice. Now, hopefully we can play this video. We'll see. Is it working?
Yeah, I hear it. Oh, wait. Not hearing it now.
Oh, shoot. Well, we can skip it. It's in there in the slides. So when you get the slides, now it won't let me stop the video.
You tried turning it up a little bit on there and see if that worked.
I don't have any volume controls.
Oh, I think I seen it on the bottom of the actual video, like if you hover over it. Well, there was. Where it went. Oh, there it is.
Oh, it's not letting me do anything with it.
It's okay.
Okay, we're just gonna move on.
I think
Sorry.
it's a setting when you try to share the video, there's like a couple buttons you can click to share the sound with people.
I did click both of those.
Oh, cool.
So that's weird. I wonder if I should, well, I don't know if I should go back and back in. I clicked them the first time, but now I'm second guessing myself. Anyhow, you'll have the videos if you want to watch them, but I'm sorry that you just now get to listen to me talk for an hour. So, all right, back to trauma-informed OD response. So If there's someone who knows the person, knows them best, definitely having that be the lead person in that trauma-informed response. Removing extra folks. If you're in a public space, having someone say, you can't walk here right now, can be really nice. Definitely encouraging going to the hospital for observation. And having the person who has the most rapport with the victim to lead that conversation. And if they decline to go, make sure that they have a space to recover that's in your view or in view of someone, or you make a safety plan to do the best you can. And anytime you have been part of an overdose response, please debrief with others who were there. It can be really, really traumatizing for us when responding to an overdose. And so it is really important that you debrief, support each other emotionally, and also, go over what happened, talk about what went well, talk about what you would do differently. That kind of thing can be really helpful. And methamphetamine overdose. Again, back in my day, we thought there was no such thing. We called it overamping. And it's actually a thing that can be deadly. This is Washington State data. Between 2008 and 2018, meth deaths increased 600%. It's gone way up from there. So I don't even want to know what that percentage would be if we move that to today. The biggest risk is overheating heat stroke, having a cardiac event like a heart attack or stroke, a seizure, or a mental health crisis. We've all either been there or know someone who has, right? And meth overdose often happens because folks use too much meth, big surprise, or they are staying up for too long, mixing drugs, or using alone where no one is there to help and recognize that they need help. And knowing when to get help for folks. So if folks have a super fast heart rate, that's an indication that they need medical attention. A high body temperature, a painful headache, chest pain or tightness, not being able to move their limbs or feel their limbs, or can't walk or move around, won't wake up. Sometimes that's kind of a difficult one, right? Like we could sleep real hard when we're sleeping it off. And so knowing when it's a medical emergency versus someone's just, out for the count. And then talking to others about overdose. I probably don't need to tell you all how much language matters. So I won't bother since you're all in recovery and in this field. But it's definitely important if you are talking to people who maybe don't know your own affiliation. It is important that we use, the best language we have, and not shaming folks for their drug use. Going over those overdose risk factors, mixing drugs, a period of abstinence, whether that's, withdrawal management, AKA detox, or jail, or, abstinence-based recovery. Those can be risk factors. Knowing the signs of overdose and how to respond. Safer use strategies may not be your biggest talking points, but those are important to share if you are educating folks about overdose. And people relapse, right? That's just a reality. And so when we are in recovery, it's a good time to educate about safer use strategies in case we return to use. Drug supply information, making sure that people know. I can't stand when people say fentanyl's in everything. It's not in everything. I don't want people to think I'm already using fentanyl. It's not in everything. It's in these blue pills, predominantly white powders, and occasionally mixed with another substance. But just because someone's using drugs does not mean they've been using fentanyl. And we went over all of those. Another risk factor for overdose is heart, kidney, liver, or lung disease. So it's important if you have residents who have those underlying health conditions that they know. Overdose education, if you want, you can get these brochures for free from the University of Washington ADAI, whose name just changed to Alcohol and Drug Addiction Institute, I think. Getting rid of drug abuse, because that's old language that stigmatizes people and leads to less quality care, and we don't want that, so we don't say abuse anymore. So the Alcohol and Drug Addiction Institute has these brochures. You can order them for free. The link should be in the slides. And so if you want to share with others overdose information, you can. Calling 911, the most important. The Good Samaritan Law protects people from being charged for drug possession. If you are responding to an overdose and the first responders arrive, they will not arrest you for drug possession. Though, if someone has a warrant, they're on DOC supervision, there is a felony charge in the mix, like don't leave a gun on the table. That would definitely not cover you from the Good Samaritan Law. And so I like to let people know that law does have some limits, just so people are informed. Safer use tips that I would love for folks to know about in case they are using, not using alone. There are, apps and phone lines you can call. If someone is going to use, they can call the Never Use Alone line or go on the website. There's also the Brave app from Canada. And that way you have someone who's there and can get you help when you're using, if you don't have another person to do that. The Brave app is kind of nice too, because they don't just call first responders. They'll call your boyfriend, girlfriend, neighbor, whoever you want to help you in an overdose event. Definitely start with a test amount. If you're going to take a blue pill, break it into tiny pieces and take a small amount to start. If you're going to use with others, taking turns. It's really horrible that everyone does the line of cocaine at the same time and everyone is overdosing at the same time and no one can help each other. And so really it's important if folks are doing, going to use, that they're taking turns and waiting in between to make sure that the supply isn't poison. Of course, trying to use one drug at a time, which can be hard to do. Testing your supply for fentanyl. Fentanyl test strips are available for folks who need them. You can purchase fentanyl test strips through DanceSafe, or if folks are in King County, they can reach out to me to get some for free. Medications for opioid use disorder like Suboxone and Methadone can lower your overdose risk by 50%. We know that when folks have a stable opioid in their brain, they're less likely to overdose on opioid. And so that can be a huge protective factor if people are on medications for OUD. Resources to share. So we have in King County the Laced and Lethal campaign. Anyone in King County can go on that website and get free nasal Narcan mailed to them. And there should be a statewide option coming soon. So I will be sure to share that with Jason and Brianna when it comes along. But for now, if you've got folks in King County, they can get free Narcan that way. A couple of the projects that I'm working on that I like to talk about is vending machines with naloxone and fentanyl test strips are going to be available in Seattle and Kent very soon. And I know that there's some other vending machines around the state, so there may be one closer to you. We're also launching a community drug checking program where folks can bring a drug sample and have it analyzed to find out what's in it. And so that project will be launching very, very soon. Our spectrometers are here and we're training technicians and getting ready for launch. So more will be revealed on that. You can order all the overdose brochures and those kind of things if you should need on the ADAI website. There's also this wonderful opioid response video, which I don't know if it's going to play, and it's in there linked for you. Maybe since I think we probably have a little bit of time, I could try stopping share and reshare to see if it will work. I just noticed that there was comments in the chat. They take the drugs on the table here too. You're probably in Eastern Washington or Southwest, maybe. Anyhow, okay, I'm gonna stop sharing and try and redo it. See if I can get it to work. Okay.
Roughly 2 out of 3 overdose deaths are linked to opioids. Today, you'll learn how to recognize and respond to an opioid overdose and potentially save a life. Opioids are drugs that include morphine, OxyContin or Percocet, fentanyl, and heroin. They slow breathing and heart rate. When a person has more opioid in their system than their body can handle, their breathing slows and without intervention could stop. An overdose can happen to anyone using opioids, but is more likely when a person uses drugs again after stopping or reducing use for even a few days, because drug tolerance can decrease very quickly. When a person mixes opioids with other drugs or alcohol. When a person uses drugs alone, because no one is there to help them in the event of an overdose. Opioids can cause people to seem sleepy, so it may be difficult to tell if someone is experiencing an overdose. A person displaying these signs and symptoms may need help. Unconscious or awake but unable to talk. Bluing lips on a lighter skinned person, ashy or white lips on a darker skinned person. Fingernails turning blue or purplish black. Slow, shallow breathing. Choking or snore-like gurgling sounds. Vomiting. Limp body. Clammy or pale face. No breathing or a slow or erratic pulse. Not responsive to shaking or yelling, and not responsive to pain, such as a sternal rub. If you suspect an overdose, shake the person and rub their sternum or pull their earlobe. Take 2 knuckles and rub and tap the person's sternum hard for 10 seconds. Call their name if you know it. If the person responds, they are not overdosing. If there is no response after 10 seconds, call 911. Give the operator your location and a simple description like, "Someone is here and not breathing. Please send help." If you need to leave the person to call 911 or for any reason, put them in the recovery position. Place them on their side and use their top, arm, and leg as kickstands. After you call 911, administer naloxone. There are 2 common types of naloxone, Narcan nasal spray and one you inject into a muscle. To use Narcan nasal spray, place the person flat on their back if possible. Peel back the film from the spray and hold it in your hand, pointer and middle fingers on the top, thumb on the plunger. Insert the spray device into the nostril as far as your knuckles will allow and push up hard on the plunger with your thumb. Give them all the spray in the device. To use injectable naloxone, place the person flat on their back if possible. Pop the cap off the vial and insert the syringe into the hole at the top of the vial. Turn the vial upside down and draw up all the liquid. Once the naloxone is in the syringe, inject all of it into the upper outer part of the thigh, or the upper arm, or a butt cheek. There is no need to remove clothing. The syringe will go through. After you've administered naloxone, begin rescue breathing if the person is not breathing. With the person flat on their back, tilt their head back by holding the chin with one hand and the forehead with the other. Pinch the nostrils shut and give 2 short breaths to verify you have a clean airway. You should see their chest rise. If you see their belly rise, readjust the position. If you do not see the chest or belly rise, check the airway for blockages. After you make sure the airway is clear, give 1 full breath every 5 seconds. You do not need to do chest compressions. If there's no change after 3 minutes, administer a second dose of naloxone and continue rescue breathing. If you administer naloxone and the person wakes up, tell them you gave them naloxone and stay with them until paramedics arrive. Make paramedics aware of any other conditions you know of that could complicate recovery. If you witness an overdose, don't wait to call for help, even if you are also using drugs. Washington's Good Samaritan Law protects you from criminal penalties for minor drug possession or having alcohol under age 21 when you get help for someone experiencing an overdose. Naloxone wears off after 30 to 90 minutes. Depending on the drugs in someone's system, they could fall back into an overdose when naloxone wears off, so you may need to give another dose. An opioid-dependent person will wake up in withdrawal after being given naloxone. Try to keep them calm and awake while the naloxone wears off. Encourage them not to use any more drugs and remind them that the naloxone will block the opioids. If you're unsure about their condition, take them to the emergency room for further observation or evaluation. In Washington state, you do not need a prescription from your doctor. There is a statewide prescription for naloxone called a standing order that anyone can use. Naloxone is a safe medication that reverses the effects of opioids. It only works if a person has opioids in their system and will not work on drugs such as methamphetamine, cocaine, or alcohol. Anyone can buy naloxone at a pharmacy using the statewide standing order. If you have health insurance, check with your provider to see if your plan will provide a kit to you for free or at a reduced cost. Store naloxone out of sunlight and at room temperature. Naloxone can work past its expiration date, but works best when not expired. Replace expired naloxone as soon as possible, but don't hesitate to use expired naloxone if that's all that's available. We hope you now feel confident to recognize the symptoms of an opioid overdose, then take action. Stay tuned for more information about where to get naloxone.
Oh, right. That's the end of the presentation. Now I'd love to hear your questions, comments, thoughts, experiences, anything that you would like to share.
Are we able to get the video as well? I know I had some staff that wanted to attend. Can we get the video too?
Yes, of course. So in the chat, I actually posted, it's going to be in on our website, www.walker.org by Monday, and it will be under the recordings page. So you can definitely go and show all your staff.
And I will send the slides to Brianna directly following this so that she can share those as well. And I leave lots of links embedded in my slides so that if you want more information or you want to access a resource that I talked about, they should be in there for you.
Excellent. Thank you very much.
Yeah, did anyone learn anything today?
Yes, for sure.
Okay. I apologize. I am not at my best today because I broke my little baby toe yesterday. But here I am, and you know,
Thank you so
hopefully I
much.
made
Yeah.
sense.
Yes, it was great. Yeah, any more questions? Now's the time.
You can also ask me questions about drug supply or other things or harm reduction interventions that you've heard about that you want to know more about. You could ask anything really.
So I wanted to thank you and glad you're in recovery. Also, it's good to know that somebody knows what things are really like. And I think a big part of that is we work here in Eastern Washington, and this shaming aspect. And I just wanted to thank you because somebody who's been in that kind of situation, you can talk very honestly to people, they who are in the depths of this, you know. So thank you very much for that. Appreciate it a great deal.
Thank you. So someone said, can you explain the experience when you responded to an overdose? So I've responded to several in my lifetime. In the 90s, we didn't have Narcan. And so what we did back then to keep people alive is drag the person outside and call 911 and pretend that you don't really know them, but you know they did some heroin. That was our way that worked back then, thankfully. Nowadays, we get to carry our own Narcan and it's a little bit different. Though it's still, you know, overdose still looks the same on opioids. So one of the worst, I will say, overdose experiences I had, I was working at the syringe exchange downtown, and someone came running in and said, I need Narcan, which, like, sometimes people are just real excited about resources. And so it's like, yeah, do you want to sign up? And it's like, no, my friend is overdosing. I need Narcan now. And it's like, oh, okay. We grab our red pouch, and I went to grab a phone, and we met out in the alley where the guy was laying flat. His friend had carried him like a block, was trying to get him all the way to us. And he just got heavier and heavier. And so he had to drop him across the street and run the rest of the way on his own. So we got to our little guy and gave him the Narcan. That's the one I was whispering to, like, you know, I'm glad you came back. I asked his friend, what's his name? So I can call him by his name. Unfortunately, when the first responders arrived, they did not take a trauma-informed stance while dealing with this young man. He was a young man of color who I assume had had some experiences with first responders that maybe didn't go so well. Safe to assume, right? And so I'm trying to let him know, like, there's first responders coming, they're firemen, they're going to help you. Well, when they arrived, they didn't take any time to orient him to any of it. They jumped right in his face. We're putting oxygen up to his nose. And, you know, we're telling him we gave, 4 milligrams of naloxone, blah, blah, blah. And because he was disoriented, which happens, and people say, watch out for someone swinging on you. No one has ever swung on me. it's not a normal response, okay? That is a response to what is happening when they're coming to. And so, of course, this young man was disoriented and tried to wave the hands out of his face that were in his face. And the police officer on scene took that as a threat against the fireman and jumped on his chest to pin his arms down. And it was a bad overdose response. The young man is still alive. I've seen him recently. So, and I know that he survived years past that overdose. But of course he wasn't going to go for observation after that situation, right? And so me as an ally in the situation, and nowadays I look like a white lady social worker, so they don't necessarily look at me like an IV drug user, right? And so I'm like, excuse me, you know, your behavior towards this person has affected their ability to get medical care. And the cop was like really intense and aggressive toward me. And thankfully, I got to have a little bit of a follow-up with him and his supervisor, and they didn't have video of the incident, but they had all of the audio, and it wasn't very pretty for this young officer. And so I encourage you, if there are things that go wrong in an overdose situation, take the time to follow up. If you have that privilege of being an ally to the community, take the time. We have to hold people accountable for taking care of our community in a trauma-informed and respectful way. And they're not just going to do that on their own. So that's one of my overdose stories. And thankfully, you know, he made it, but it could have been bad. And it could have been all because of a non-trauma informed overdose response by first responders.
Yeah, I see another question here. It says, do you know if / where Narcan will be available to the public in Thurston County, similar to the program that you mentioned for King County?
Yeah, syringe service programs can be some of the best places to start, though depending on resources, you guys probably have a lot of a need. But if you're looking for like your own doses, head to a syringe service program. They're usually the best first place to start. Nowadays, Safeways, Albertsons, most of the major pharmacy chains are stocking nasal Narcan. What your insurance may cover is, you know, an additional consideration. So I know like my parents, my stepmom broke both her arms and she got some opioids and they responsibly prescribed her naloxone, but it cost her $125 from the pharmacy, which is not a great thing. So definitely know that there are free resources out there, but it may take a little bit of digging. Your local health department, thank you, Cindy, can be a good place to start as well. They may be able to direct you somewhere. Though I do believe that Washington State Department of Health is going to be launching a statewide mail-based naloxone very soon. So hopefully I can share that. And if you're ever in King County, you can always stop in and use some, get some Narcan here. Narcan is totally safe. If you have no opioids to be kicked off a receptor, it's not going to do anything. So kids having Narcan around, you don't need to put Narcan up where kids can't get to it because it really doesn't harm anyone. I have a friend who was doing an overdose training and she was demonstrating the auto injector and accidentally used the live one instead of the demo. And in the middle of a Narcan training, she Narcaned herself in the leg by accident. And it was a great way for her to demonstrate, see, not opioid dependent, no problem. So if someone is opioid dependent and they're given naloxone, they're going to have precipitated withdrawal. It's going to come on fast. It's going to not feel good. And so really just understanding that people won't feel well and they'll be disoriented and afraid. And so just thinking about if you were in that situation, how would you want folks to be responding to you, right? Anyhow, I hope that you guys got something, and you can always reach out to me anytime if you have questions or need help connecting to a resource, or just want to chat with somebody about harm reduction or overdose prevention. I'm here for y'all.
We're getting half of what you're saying.
Oh,
You're
be
cutting
my
in and out.
Wi-Fi. I'm here if you need anything, was the whole point.
I got a question. So I don't know if someone had asked it, but what if like the younger children, like say the 12 between 18, what if they are using opioids and we use the naloxone on them? How does that affect them? Is it different than an adult, or does it just affect them the same way?
Same way, same system, same response. Yeah. And right now you may have seen a lot of news that's come out this week that although teenage drug use has gone down, teenage overdose has gone up due to fentanyl.
I see a question from Thomas that says, isn't law enforcement trained in Narcan use too?
They know how to give Narcan, most of them.
Mhm. I would, Thea, I'm curious to know about the vending machine system you're talking about. Can you explain that a little bit?
Yeah, so we bought a couple of vending machines and we're stocking them with nasal Narcan, injectable Narcan, fentanyl test strip packs, and condoms and lube for now. They are available at the Pier Seattle and Pier Kent locations. They provide peer-based support for folks who have substance use or other behavioral health conditions or medical conditions like HIV. And so they do a lot of wonderful peer support on site and have support groups and things. So Pier Seattle and Pier Kent are going to be our two pilot locations. Folks will be able to sign up online and go into the machine and put their code in to get their supplies, or they can sign up on site with help from staff at Pier. They're going to launch any second. I was actually on my way to go and test the Seattle machine when I broke my toe yesterday. There's also a vending machine with Narcan available. It's like Central Washington, and I can't remember what community. But there is definitely talk of expanding vending machines as a access point beyond King County. And so definitely this is, it's a way of providing harm reduction services that's a bit more confidential, and research has shown that younger people especially are more likely to use a vending machine than walk into like a syringe service program and ask for naloxone. And so we're just trying to find different ways to meet people where they're at, and knowing that not everyone is going to go to a needle exchange for supplies. You know, folks who use drugs in different ways oftentimes just don't feel like that's the right space for them. Some of our syringe service programs do a good job of meeting other drug use needs, like People's Harm Reduction Alliance is doing smoking supplies and all the bells and whistles. And so I think they may meet a different group, but yeah, it's definitely an exciting time for trying new things. And they will be free. Yep. So folks can sign up and get once a week, they can get a Narcan and test strip pack for free. Safe injection sites. Well, I mean, as much as they've always been, we don't have any plans for like a big insight type supervised injection space anytime soon, though we still have the same situation that we've had for the last several years. There's active bathrooms throughout the city. I'd rather see people supervised while using. It would be safer, but until then, folks are still going to be behind closed doors predominantly. And yeah, hopefully we'll have some supervised consumption available someday, but it's a tough situation with our federal laws, really, that it's hard to know what's going to happen. And so until we have more of a clear indication from the federal government what their response will be, I don't know that we'll have a full-on supervised consumption site available. Any other ideas, questions, comments, feedback? By all means, if I said something whack, I want you to tell me. I'm always open for feedback, and I want to improve my cultural competence. So if I said something that landed in a way that didn't feel good, I'm definitely open to receiving that information. Okay, friends, it may be the end of our training today. Thanks so much for having me.
Yes, thank you so much, Thea.
Thank you.
And I will look up the email that everyone has used to register for the event. I'll be able to send an email out with the slides to everyone. And then again, it will be on our website, walker.org, under recordings as well. So thank you guys all for coming. Bye-bye.